Welcome, everyone. Let's begin by establishing a precise clinical definition of chronic obstructive pulmonary disease, or COPD. According to current global standards, COPD is defined as a common, preventable, and treatable disease. This is a crucial starting point. It reminds us that this condition is not an inevitable decline, but one we can influence. Clinically, it is characterized by persistent respiratory symptoms and airflow limitation. Unlike the episodic nature of some other lung conditions, this limitation is constant. This occurs because of structural abnormalities within the airways, the alveoli, or often both, representing the pathological hallmarks of chronic bronchitis and emphysema. What drives these changes? In most cases, they are caused by significant, long-term exposure to noxious particles or gases, such as tobacco smoke or environmental pollutants. This definition provides the framework for understanding COPD as a chronic response to inhaled toxins leading to permanent structural impairment. Let's examine the underlying causes and mechanisms of COPD. Tobacco smoking remains the primary culprit, accounting for over 80% of cases. However, we also see significant contributions from alpha-1, antitrypsin deficiency, occupational exposures to mineral dusts, and indoor air pollution from biomass fuels. Pathophysiologically, chronic inflammation drives two parallel processes: obstructive bronchiolitis, which narrows the small airways, and emphysema, characterized by the destruction of lung parenchyma. This tissue damage is rooted in a critical imbalance between proteases and antiproteases. As the lung tissue breaks down, we see a loss of elastic recoil and subsequent gas trapping within the alveoli. Ultimately, these structural changes culminate in a persistent airflow obstruction that is not fully reversible. Understanding this permanent remodeling is essential to grasping why the airflow limitation in COPD remains so stubbornly persistent compared to other respiratory conditions. When diagnosing COPD, we focus on a characteristic clinical pattern. Patients typically present with progressive dyspnoea that worsens on exertion, often alongside a chronic cough and persistent sputum production. On examination, you'll frequently hear an expiratory wheeze. Look for physical signs of hyperinflation, specifically an increased AP diameter of the chest. You may also observe the patient using accessory respiratory muscles or employing pursed lip breathing to facilitate airflow and manage their work of breathing. In advanced cases, keep a keen eye out for peripheral cyanosis, indicating significant hypoxia. Finally, be alert for signs of right heart failure, or cor pulmonale, which marks the systemic progression of the disease. Identifying this specific constellation of symptoms and physical findings is the critical first step in confirming a clinical diagnosis of COPD at the bedside. Now, let's focus on the diagnostic criteria for COPD, as defined by the GOLD classification. Diagnosis begins with clinical suspicion. We look for the characteristic presentation of chronic cough, regular sputum production, and persistent dyspnoea. These symptoms gain significant clinical weight when paired with a history of exposure to risk factors, most commonly tobacco smoke, though we must also consider occupational dusts and chemicals. However, while the diagnosis is clinical, it must be confirmed through objective measurement. The gold standard is post-bronchodilator spirometry. We are specifically looking for evidence of fixed airflow obstruction. This is defined by a post-bronchodilator FEV1/FVC ratio of less than 0.70. This specific ratio confirms that the limitation is persistent and not fully reversible, distinguishing COPD from other respiratory conditions. Integrating these clinical symptoms and risk factors with this physiological hallmark is essential for an accurate diagnosis. Now, let's focus on the investigations. The gold standard for confirming a COPD diagnosis is post-bronchodilator spirometry, specifically looking for a fixed airflow obstruction with an FEV1/FVC ratio of less than 0.70. Our initial first-line workup also includes a chest X-ray, where we look for signs of hyperinflation, flattened diaphragms, or bully, and a full blood count to screen for secondary polycythemia. To refine our diagnosis, we utilize supporting tests. Transfer factor for carbon monoxide, or TLCO, is typically reduced. In younger patients or non-smokers, we must screen for alpha-1 antitrypsin deficiency. High-resolution CT helps us identify emphysema or coexisting bronchiectasis. Finally, we must address cardiovascular differentials. An ECG and echocardiogram are indicated if cor pulmonale is suspected, while a BNP is essential to exclude heart failure as the primary cause of the patient's breathlessness. These investigations ensure a robust, multifaceted diagnostic approach. Moving to management, our strategy focuses on smoking cessation, the only intervention proven to slow FEV1 decline, alongside vaccinations and symptom control. We begin with short-acting bronchodilators. If symptoms persist, therapy is stepped up based on clinical phenotype. For those without asthmatic features, we use a LABA/LAMA combination. However, if there's a history of atopy or high eosinophils, we initiate LABA plus ICS, moving to triple therapy if exacerbations continue. Supportive care includes pulmonary rehabilitation for patients with an MMRC score of 2 or more, and long-term oxygen therapy for those meeting specific PaO2 criteria. We may also consider prophylactic azithromycin or roflumilast. During acute exacerbations, maintain target saturations between 88 and 92%. Manage these with nebulized bronchodilators, systemic prednisolone, and antibiotics for purulent sputum. Finally, if respiratory acidosis persists despite 1 hour of medical management, non-invasive ventilation is indicated. This structured approach optimizes both chronic stability and acute recovery. Moving on to our MRCP high-yield pearls. First, it is crucial to remember that smoking cessation remains the most effective intervention for improving a patient's prognosis. If prescribing long-term oxygen therapy, emphasize that it must be used for at least 15 hours daily to confer any mortality benefit. Clinically, look for secondary polycythemia, with a hematocrit exceeding 0.52 as a classic indicator of chronic hypoxemia. In cases of alpha-1 antitrypsin deficiency, expect panasonar emphysema, characteristically involving the lower lobes. To differentiate COPD from asthma, focus on the TLCO, which is reduced in COPD but remains normal or high in asthma. In acute exacerbations, the primary indication for NIV is persistent respiratory acidosis, a pH between 7.25 and 7.35, following optimal medical therapy. Finally, watch for cor pulmonale. Characterized by peripheral edema, a raised JVP, and a loud S2, it is managed through diuretics and LTOT. And that brings us to the end of today's session. I hope this has been a valuable and clear overview. To truly consolidate this knowledge, I encourage you to take the next step. Visit our online platform at mrcpelite.com. There, you can create a free account instantly. You will find a structured slideshow summarizing today's topic, followed by 2 dedicated self-assessment tests. One for MRCP Part 1 and another for MRCP Part 2, each containing 20 focused questions. Take these tests to actively engage with the material. The platform will provide you with an immediate score and, most importantly, detailed, illustrated explanations for every answer, helping you fix the information firmly in your mind. To supercharge your preparation, consider upgrading to a pro user subscription. This unlocks powerful tools, unlimited disease-specific search queries, unlimited access to high-yield exam pearls, unlimited interactive flashcards, and most critically for your exam readiness, full exam board access with 50 question banks for every MRCP subject, and realistic mock exam simulations for both Paper 1 and Paper 2 that closely mirror the actual exam environment. For a limited time, we are running an exclusive offer. Gain all these pro benefits for just $50 for a full year, a significant saving from the standard price of $250. So, head to mrcpelite.com now. Start with your free account, test yourself, and explore how the Pro upgrade can transform your revision journey. Thank you for your time and all the very best for your studies.